Picture a 47-year-old guy. Fit enough. Works hard. Gets a bit winded on the stairs but figures that is just age. One Tuesday morning he drives himself to the hospital because his chest feels tight. The doctors run his bloods. His LDL cholesterol has been quietly sitting at 158 for probably a decade. Nobody ever told him what that number meant. Nobody ever explained what was building up inside his arteries the whole time. That is the video we are making today. Because the information that could have changed his Tuesday was always available. He just never got it in plain language. Here is something worth knowing before we get into the numbers. Cholesterol is not the villain it is sometimes made out to be. Your body actually makes it on purpose. It is essential for building cell membranes, producing hormones including testosterone, and synthesizing vitamin D. Without cholesterol, your body simply does not work. The problem is not cholesterol existing. The problem is too much of a specific type of it floating around in your bloodstream for too long. That distinction matters more than you might think, and it shapes everything we are going to cover today. Let me paint you a picture of how common this actually is. Around 86 million American adults over the age of 20 have total cholesterol at or above 200 milligrams per deciliter. That is the threshold where doctors start paying attention. About 24 million of those people are above 240, which puts them in the very high category. These are not rare numbers. These are your neighbors, your workmates, the bloke standing next to you at the hardware store. And the majority of them feel completely fine, which is exactly the problem. So what exactly are we measuring when we talk about cholesterol? Your standard blood test, called a lipid panel, gives you 4 numbers. Total cholesterol, LDL, HDL, and triglycerides. LDL is the one that does the damage when it is too high. Think of it as the type that gets into the artery wall and starts building up plaque over time. HDL is often called the good type because it helps carry cholesterol away from the arteries. And triglycerides are a separate fat in your blood that also matters for your overall risk. The CDC describes optimal levels as total cholesterol around 150, LDL around 100, HDL at least 40 in men, and triglycerides below 150. All in milligrams per deciliter. Now here is where men specifically need to pay attention. Men tend to have higher LDL and lower HDL than women, right up until around age 50 to 60. And coronary heart disease, the kind that causes heart attacks, shows up roughly 7 to 10 years earlier in men than in women on average. So if a woman in your family had a heart attack at 65, the equivalent risk window for a man in that family might be closer to 55. That gap is not a small thing. It means the clock starts ticking earlier for us, which is exactly why the conversation about checking your cholesterol needs to happen sooner than most men think. Most people get this completely wrong, so let me fix that. High cholesterol has no symptoms. None. You do not feel it the way you feel a sore knee or a headache. There is no warning signal your body sends you. The symptoms that do eventually show up, things like chest pain, shortness of breath, or a stroke, those are not caused by the cholesterol itself. They are caused by the damage the cholesterol has already done to your arteries over years or even decades. By the time symptoms arrive, the disease is well established. This is why waiting until you feel something is genuinely dangerous. Screening is the only way to catch it early. So when should you actually get checked? This is where the guidance has shifted significantly in recent years. The older approach in the United States was often to start routine cholesterol checks at around age 35 for men. The newer thinking, informed by the American College of Cardiology and the American Heart Association, pushes that starting point much earlier. Current guidance encourages cholesterol testing for adults starting around age 19, with periodic repeats after that. Some organizations even recommend an initial screen between ages 9 and 11 to catch inherited conditions early. One expert put it plainly in 2026. One of the most important changes is that the guidelines widen the window for checking cholesterol levels, starting at age 19. Here is the research that should genuinely motivate you to act. Large-scale studies show that for every 39 milligrams per deciliter you reduce your LDL cholesterol, you get roughly a 20 to 25% relative reduction in major vascular events. That means non-fatal heart attacks, strokes, and procedures to open blocked arteries. And there are 4 rules that modern guidelines keep coming back to. The earlier you lower LDL, the greater the lifetime benefit. The bigger the drop, the bigger the risk reduction. The higher your starting LDL, the more you stand to gain. And the higher your overall cardiovascular risk, the more aggressively lowering LDL actually helps you. Let us talk about the actual target numbers, because this is where a lot of men get confused by conflicting information. For the general population without known heart disease, the goal is to keep LDL below 100 mg per deciliter. If you have risk factors like diabetes, the target drops to below 70. And if you have already had a heart attack or stroke, current guidance in many settings targets LDL at or below 55 mg per deciliter. The direction of travel in global guidelines is clear: lower is better, especially for people who are already at elevated risk. These are not arbitrary numbers. They come from decades of trial data showing real reductions in real events. Sound familiar? You have had your cholesterol checked, the doctor said it was fine, and you moved on. Here is the catch. Total cholesterol can hide a dangerous pattern underneath. You could have a total cholesterol reading that looks acceptable, while your LDL is elevated and your HDL is low. That combination is far more meaningful than the headline number. Modern guidelines focus specifically on LDL level, non-HDL cholesterol, and particles called ApoB-containing lipoproteins, not just the total figure. So if your doctor has only ever mentioned your total cholesterol and not broken it down, it is worth asking for the full picture next time you are in. And here is the million-dollar question. What if your standard cholesterol panel looks reasonable, but you still have a significant inherited risk that nobody has tested for? That is where lipoprotein A comes in. Lipoprotein A, often written as Lp(a), is a cholesterol-related particle that is almost entirely determined by your genetics. Lifestyle changes, exercise, diet, and even standard cholesterol-lowering medicines have very limited impact on it. High levels, typically defined as above 50 mg per deciliter, are a major inherited risk factor for premature heart disease and aortic valve disease. Updated guidelines from both the United States and Europe now recommend that every adult get this tested at least once in their lifetime. There is another test that has become increasingly relevant for men in their 40s and 50s who sit in that uncertain middle ground, not clearly low risk, not clearly high risk. It is called the coronary artery calcium score, or CAC scan. It is a CT scan that measures the amount of calcium deposited in the walls of your coronary arteries. Calcium there is a marker of established plaque. If your score comes back at 0, that is genuinely reassuring and can, in guideline discussions, support a decision to hold off on medication in the short term. If it comes back elevated, it tells your doctor that plaque is already forming and that more aggressive management is warranted. It is generally considered for adults in their 40s to 60s with risk factors like prediabetes, family history of early heart disease, or borderline high cholesterol. One thing worth flagging separately: if your LDL comes back at 190 mg per deciliter or above, the guidelines essentially say do not bother running the standard risk calculator. The risk is assumed to be high enough that aggressive management is warranted regardless of your other numbers. In many men with LDL that high, an inherited condition called familial hypercholesterolemia is the underlying cause. It means their arteries have likely been exposed to elevated LDL since childhood, which is exactly why some guidelines now recommend an initial cholesterol screen for children between ages 9 and 11, specifically to catch this condition before decades of silent damage accumulate. Let us talk about what happens if your numbers do come back elevated and your doctor recommends treatment. There are several categories of medication used for this, and it is worth understanding what they are and why they exist, even if the decision about whether you need any of them is entirely between you and your doctor. Statins are the first-line treatment for most people at increased risk. They work by reducing the amount of cholesterol your liver produces and by increasing the liver's ability to clear LDL from the blood. Ezetimibe is often added when LDL is not low enough on a statin alone. It works differently. by reducing how much cholesterol is absorbed from the gut. These are the two most commonly used options and both have substantial long-term trial data behind them. For people at very high risk or those who cannot tolerate statins well, there are newer options. PCSK9 inhibitors are injectable medicines that can substantially lower LDL and are reserved for people who need more aggressive treatment. There is also a newer injectable therapy called inclisiran, given just twice a year in a clinic, which reduces LDL production in the liver through a different mechanism entirely. These options exist because for some men, particularly those who have already had a cardiac event, getting LDL down to 55 or even lower is the clinical goal, and diet and standard medication alone may not get them there. The key point is that treatment decisions are made through shared discussion with your doctor, weighing your specific risk, your numbers, and your circumstances. Before we wrap up, let us knock down a few myths quickly because they genuinely get in the way of men taking this seriously. Myth 1. If I feel fine, my cholesterol must be fine. We have covered this. It is silent. Feeling fine tells you nothing about your LDL. Myth 2. I can fix high cholesterol quickly with a supplement or a short-term diet change. Short-term shifts in diet can move the numbers slightly, but cardiovascular risk is about cumulative exposure over years and decades. Supplements marketed as cholesterol cleansers are largely unproven and not regulated the way medicines are. Talk to your doctor before spending money on any of them. Myth 3. High HDL cancels out high LDL. It does not. Trials that specifically tried to raise HDL with medication did not reliably reduce heart attacks. The focus in modern guidelines is on lowering LDL, not on chasing a higher HDL number. Here is what I want you to take away from all of this. Cholesterol is one of the clearest early warning lights your body has for heart attack and stroke risk. The science on this is not contested. The guidelines have shifted in a meaningful direction. Check earlier, know your LDL specifically, ask about lipoprotein A at least once, and if you are in your 40s or 50s with risk factors and your doctor is on the fence about medication, a coronary calcium scan might be the thing that tips the decision one way or the other. None of this requires you to become a medical expert. It just requires you to walk into your next appointment knowing what questions to ask. That is the whole point of this channel. If this video gave you something useful, the best thing you can do right now is share it with someone who needs it. A mate who keeps putting off his checkup. A brother who had a scare last year. A dad who thinks he is fine because he feels fine. Hit subscribe if you want more of this kind of content, where we take the research seriously and explain it the way a knowledgeable friend would, without the jargon and without the scare tactics. There are more videos on this channel covering the tests and symptoms that matter most for men's health, and I will see you in the next one.